I now have the great pleasure to welcome our responsive panel to the main stage. The panel is titled Improving Mental Health Access, Taking Mental Health Parity to the Next Level. And I want to introduce my dear friends and colleagues, Kay Matthews of the Shades of Blue Project, who you heard about earlier, championing the authorization for community-based organizations. Also Karen Howard of Mental Health America, who's a real champion for mental health parity, and so much more. And also former state Medicaid director, Gretchen Hammer. We're honored to have you with us as a payer and to share your perspectives. And I now like to introduce Marilyn Serafini, who will be joining the panel to moderate this important discussion. Marilyn is the executive director for the health program at the Bipartisan Policy Center in Washington, D.C. She's also an adjunct professor at Johns Hopkins University and has served as the executive director of a consumer advocacy organization addressing heart disease. She's also served as the president and co-CEO for the Alliance for Health Policy, who we know well, and for more than 20 years has also been an award-winning journalist covering healthcare, welfare, and more in Washington for various news outlets. She was the Robin Toner Distinguished Fellow and Senior Correspondent at Kaiser Health News, and was a correspondent for many other well-recognized news outlets. It's sure a pleasure to welcome you to the main stage as a moderator, Marilyn, and also this esteemed panel. Over to you.
Great. Thank you so much, Joy. This is just a fantastic panel. I'm delighted to be here with everyone today. And it's an issue that we at the Bipartisan Policy Center have been focusing on very intently, not just parity, but also maternal mental health in general, maternal health, mental health, and maternal mental health. So we know that we have a lot to work on. We've made a lot of progress, but we have a lot to work on, especially as it relates to parity issues and making sure that we have access, people have access. The need is great. So I'd like to get right into our conversation. And as Joy mentioned, we've got a great group here, and Amber is going to continue to be with us for this part of the discussion. So I'd like to turn it over to the other folks, Karen, Kay, and Gretchen. And if each of you could just take a couple of minutes to introduce yourselves and your organizations and what your not what your thinking is, but what you are working on this area, but just very briefly, because we're going to get right into the conversation. So let's go ahead and start with Karen from Mental Health America.
Hi, everyone. I'm Karen Howard. I'm the Director of Policy and Advocacy at Mental Health America, which is a consumer advocacy organization that's been around since 1909. It was started by a man with mental health conditions who experienced a psychiatric break after attending an Ivy League school. He experienced some abuses in the public mental health system and also some shame and stigma, which is still prevalent today. So we've been part of the advocacy movement over the last over 100 years. And our largest program is an online screening program. The number one demographic of those 10,000 people visiting the screening daily are between the ages of 11 and 17 years old, so a very young, help-seeking population. And I'm really excited to be here today to discuss some of the things that impact consumers from our perspective when it comes to parity, including some of the questions that will be asked on treatment limitations and otherwise. So thank you so much.
Great, thank you. Kay?
Hi, everybody. Kay Matthews, Executive Director and founder of the Shades of Blue Project, where our primary focus is around maternal mental health, but all of what that entails. We look at social determinants of health and the way in which we offer our programs. We've been doing this work for about 10 years, and so a lot of our focus has been around what is going to best help us to help our community. So that includes a lot of things outside of our social support services. That includes advocacy work, which is what I've been doing with 2020 Mom, and others. And so I'm definitely looking forward to this conversation around the workforce. Like, how can we do better at that and think outside the box? So definitely looking forward to the conversation.
Gretchen?
Great. Hello, everyone. My name is Gretchen Hammer. I'm the founder of the Public Leadership Group, which is a boutique consulting firm that works with health and human services leaders across the country, mostly on maternal and child health programming, and in particular, trying to better design and align programs to meet the needs of families. As Joy mentioned, I also had the opportunity to serve as the Medicaid director in Colorado for about 4 years. And prior to that, spent time as the executive director of a consumer advocacy organization for low-income and uninsured individuals in Colorado.
Great, thank you. And of course, everyone has already met Amber. So let's just start from the very beginning. Each of you comes from a different perspective here. So when you think about mental health parity, what does that mean for each of you and for your organizations? What does that look like? And let's start with Kay.
It's a way to really talk and involve the community. I look at it in different lenses because, like you said, we all come from different backgrounds. Although our main purpose is around maternal mental health, we look at infant mental health, adolescent mental health, all this big view and this big lens of all of this, and how we're really going to tie that in across the board. So when I think about the parity, I'm looking at it through so many different lenses. But again, the workforce solution piece is what really sticks out to me as a community organizer and leader. That's where we best fit, and that's also where we can really fill in the gaps. So that's what comes to mind. So many different things, but that piece right there is a lot of what we're focusing on.
Karen, what does mental health parity? What does that look like from your perspective? What are the various components that you're thinking of when you think of parity?
When I think of parity, I think about how easy it is to pick up the phone and call a primary care provider to get, a appointment for a cold or flu, or how easy it is to enter urgent care or a hospital and receive treatment for a broken ankle or arm, and that we don't ask people to wait on average 11 years before they can connect to services that are appropriate for them. And right now, that's what research shows. There's about 11 years between when signs and symptoms of a mental health condition first present and when a person actually connects to services. So we need to be thinking more upstream and providing the payment and reimbursement, as well as the infrastructure or the provider infrastructure for individuals to get good care.
Yeah. Gretchen, what are the parity considerations when you look at it through the Medicaid lens?
Yeah, thank you. And Amber did such an amazing job over giving the overview of parity. The Medicaid story is a little bit a story of parallel process. It wasn't until 2016 that there was clarification by CMS about the expectations of Medicaid and compliance with parity. And so following that, as Amber said, there was a required analysis that had to be done by every Medicaid agency for certain components of the program, for managed care programs, for CHIP, and for states that have expanded Medicaid for their what's called alternative benefit packages, or the packages that are available to the expansion population. So in some ways, the lens can be quite limited and can be a compliance lens. Can we just simply be compliant? Can we write the report? Can we, answer the questions? Hopefully, though, that's not the extent of the lens with parity. Hopefully, it extends to what I believe most of my Medicaid colleagues and myself certainly felt, which is, can we ensure that our benefit packages and our service delivery is meeting the needs of beneficiaries? And when you think in particular of maternal mental health, 40% of the births in the United States are financed by Medicaid. And so a significant requirement to sort of put our best thinking caps on as we think about parity in maternal mental health, given the extraordinary role Medicaid plays in financing of perinatal care.
And Gretchen, just can you extend that a little bit further to talk
Sure.
about what happens to moms on Medicaid once they do give birth? Some of them remain,
Sure.
some of them
So
don't.
yeah, so traditionally the extension of pregnancy-related Medicaid, so you're eligible for Medicaid because you are pregnant, expired at 60 days. And so in states that had not yet expanded Medicaid, or states who had a differential between pregnancy Medicaid eligibility and adult Medicaid eligibility, many women lost coverage at that 60-day mark. So there is now, thanks to the American Rescue Plan Act, an option for states to extend that coverage for up to 12 months or up to 365 days, so an additional 10 months. Really championed by, I'm sure, almost everyone on this call. ACOG carried a lot of focus on this. And so it's really an opportunity for us to think with a new lens on parity during that extended coverage period, because we in some ways might have lost coverage for those women and those birthing people, but will now have the chance to think differently about how to provide mental health supports. And early data out of an analysis in the state of Texas shows that in fact, mental health is claims are some of the highest access services in that an early extension period.
Awesome, thank you. So when we think of parity, a lot of times we're thinking of payment parity. What is the cost sharing? What are the payments? What does the financial side look like? But let's talk for just a minute about the non-quantitative treatment limitations, things like network adequacy. So what falls into that bucket? What other than the money piece of this, what aren't we thinking about here? What are the various components? And it's complicated because you can't just say, okay, networks, you must be equal. There are a lot of complicating factors, including workforce challenges right now. And, Kay, I know that's something that you think a lot about. So Kay, maybe you could start off by talking to us about the challenges there with some of the non-quantitative treatments, limitations, and what are some of the answers. And I think you've got some of your answers just in peer supports and such. So take it away.
Great, thank you, Marilyn, for first starting out with the peer support, because a lot of us, so mental health comes with a stigma, right? A lot of things come with stigma, but I think mental health is a big one of those, right? And so if we can find someone that we can talk to, that we identify with, that we have some type of correlation with, it leads to kind of lift that stigma, right? And so when we think about workforce solutions, we are often not including the community. As a community organizer and leader, we are serving the very people that are coined the community, right? We listen to what they say, how they say it, what it is they're saying that they want to get in return, how it is they want to be treated. And typically a peer support person can definitely do that because it's more relatable, right? But how do we get one peer support specialist trained, valued, and paid for that? Because that can't be done free. That needs to be paid. So if we're going to be filling in the gap for the workforce, it's workforce, right? So workforce typically should come with some type of payment. So when we're thinking outside the box in that way, we have to be allowing folks to come in who have that experience, because there's lots of peer support training models out there, right? So folks are seeing the value in it, but the monetary piece that is tied to that is not being seen. That's where the devalue comes in. We often expect folks to do these things for free. And in the capacity in which we need them to be doing it, there has to be some type of compensation. So workforce that includes the community, because all it does is we just need to be trained on how to do it. We can step in. Of course, if you can go to school to be a doctor, a nurse, or a psychiatrist, that's not necessarily what you're trying to do, but you're wanting to help out in a way in which you have the capacity to do it, right? So based on the type of training that you receive. But I think the biggest piece of that is placing value on what the community actually brings to the table is one thing that we really need to start looking at. And again, peer support models, they work. We use them every day on the daily within our organization. And I'm sure many of you do. You see the value, but we need to also start to see payers to seeing the value in compensation to be laid across the board in that way.
So Karen, can you help us to put some of this into perspective regarding network adequacy? We know there are problems. What does it look like when patients are getting into networks in the area of mental health to try to find, how hard is it for people to find a provider in a network? And what are the reasons? What are they finding when they go into the network?
Sure. So networks are oftentimes both in Medicare, Medicaid, and private insurance plans, not providing services to new patients. They may be filled with provider names who have actually not seen any patients in the last year. In fact, there was a Medicaid study that came out saying in one network, there were 0 providers that had provided any behavioral health care in the last year. However, they were listed as, accepting new clients as a part of the network. So then what are you paying for? There's, Milliman's study from 2020, I believe, that came out basically saying that people were having to pay out of pocket at exorbitantly high rates for behavioral health care in comparison to physical or surgical benefits. And that basically means that you're restricting access to a certain people who have disposable income to come out of their pocket and pay for service and care that may very well be necessary, but not affordable. And so in addition to the kind of payment issues, the availability of clients, as a consumer, I don't know about all of this complexity that's happening on the back end. And to me, it might feel like a moral failing. It might feel like, I've tried to call 3 different people in the last week to set up a first appointment because I'm experiencing distress, and the fact that I haven't gotten a call back or I haven't been able to reach someone at all makes me feel worse because I'm going through something, I'm trying to reach out for help, and I'm being met with nothing. So then people forego care and end up maybe going into crisis or having other issues that are higher costs. You might end up going to an emergency room or having thoughts of suicide and self-harm, where you may call out to or text the new 988 number for crisis care. And in some, rural communities especially, that might elevate things to a point where law enforcement is sent out because there's no mobile crisis in the area. So you're elevating, and we know law enforcement are not trained in behavioral health and often escalate rather than de-escalate behavioral health crises situations. So all of these issues really end up being problematic for consumers and individuals, and we really need to see some bold action, including Senator Bennett's Parity bill, which we might discuss a little bit more later.
Yeah, tell us a little bit about that bill, because that's front and center. It just happened.
Sure, just this week. The senator's bill, actually, Mental Health America worked on crafting provisions. Shout out to Nathaniel Counts, who now works for the New York City mayor. But there's, first of all, health plans oftentimes will not allow pediatricians to do screenings or other basic kind of education around mental health. Well, they can spend the 15 or 30 minutes doing that, but then the health insurer says, no, we're going to deny this. You're not a behavioral health provider. You can't provide behavioral health services. If you do, we won't reimburse for it. So there's a provision in Senator Bennett's bill that will incentivize an increased payment for pediatric kind of services, pediatric mental health services to be offered to young people. There's also a requirement for parity across Medicare Advantage, Medicare Part D, and Medicaid. And so there's provisions to enforce that. We still don't see parity in Medicare, and there are big gaps in coverage in Medicare. But if we start with some of these smaller parts of Medicare, we think we can improve and get more support for the bigger Part A. The bill also ensures that Medicare Advantage plans maintain accurate and updated provider directories for beneficiaries so they can understand who's in the network. It encourages integration between behavioral and physical healthcare. And one of the things that's been difficult is that practice transformation to incorporate behavioral health into primary care. But what we also know works is putting primary care into behavioral health. So if a practice can expand and transform and maybe meets a person's other needs in the same location, that also works and is a way to more quickly integrate behavioral and physical health care, which, you know, by design, because of the consumer advocacy movement, those two were separated out. So there's, you know, there were advocacy efforts to pull and separate mental and behavioral health care from physical and surgical benefits. And now we see that did not work. It was almost like separate but equal. It was just, you know, not the same. So we need to reintegrate it back in. And so there's some attitude, cultural, education, training changes that need to be made to ensure that more people are aware of the importance of doing that integration. And then overall, there's some increased accountability and oversight of integrated care in Medicare and private insurance plans in the bill. We're really excited about it, and we're glad that he worked with Senator Wyden on the bill, but hope we can find some Republicans to co-sponsor and really get invested in this as well as an issue that's bipartisan.
Okay, thank you for bringing us up to speed on that. I'll just add one thing to what you said, Karen. You're talking about behavioral health and primary care integration, and that is something that we at the Bipartisan Policy Center have also been focusing on. We have had several reports in this area with federal policy recommendations to enable that. And one very strong reflection of how significant the access issues are and the shortage of behavioral health specialists, in particular, those who are in network, because if you're not in network, then only the people who can afford to go out of network are getting care. But one of the things that we did was we conducted a national survey and found that 39%, this is just with adults, but 39% of adults who are already receiving mental health care were getting it through their primary care provider. It's not much more for those who are receiving it through a psychiatrist, psychologist, clinical social worker, or some kind of behavioral health care specialist. So it's already happening that primary care is taking a lot of this on, even though the primary care folks are the first to tell you that they mostly don't feel trained up enough to do that. They don't feel well paid enough to do that. It takes time to do mental health and substance use disorder treatment. So I just thought I would add that. Karen, did you look like you wanted to pop back in. You're on mute.
Yes, I just wanted to mention one more kind of important part of the bill, and it's really trying to get into the payment, the access, and the outcome measures that are typically used to evaluate whether or not a practice is doing the right thing. It really tries to get those better aligned in CMS, and you know, CMS is kind of the model or rubric for other health plans to follow. So, you know, if you know, in 2 or 3 years we see some additional like measurement for quality and reimbursement for these services in primary care, we think it would just go a really long way.
So Gretchen, let's build on some of that. We've been talking about the workforce a little bit, and we understand that one potential non-compliance issue that insurers need to address is that on the medical insurance side, insurers have to ensure that there are enough subspecialists also, such as cardiologists, dermatologists, and on the mental health side, behavioral health insurers haven't been tracking whether there are sufficient numbers of child psychologists, or in the case of maternal mental health, certified maternal mental health providers. Can you help us to understand that a little better?
Sure. So it is a challenge, and something I think that needs to have continued thought about that, and the concept of parity across provider types. I think we may see, because of the postpartum extension opportunity, some more thought on that. Certainly, I know in Colorado, when we expanded Medicaid, for example, we recognized we didn't have a lot of urologists in network because we hadn't had a lot of adult men who were part of our program, or adults in general. So there is often can be a little bit of a lag in understanding the needs of your provider network when you make a coverage change. So hopefully we'll get more attention to that with the postpartum extension coverage opportunity. And so I do think it's something to think about. However, I also would caution everyone to think about where's the best place to spend sort of innovation capital or political capital. You know, network adequacy is incredibly important, just as we were just discussing, but so are other things that we've also been discussing. Utilization tracking, for example, you know, network adequacy is what we use to consider sort of potential access. It's who could potentially be available. When you actually have the chance to look at your utilization data, you understand what services have actually been used within your network, and you can track those and make sense of them. So I think there's opportunities for parity thinking in tracking utilization, also in tracking quality, as we just discussed. I think there's a real opportunity with quality measures, making sure you have parity across your quality measures by subpopulation, not just a behavioral health, perhaps a maternal mental health quality measure set that you're tracking. In particular, Colorado just added a perinatal mental health measure to our hospital quality improvement program. So there's opportunities to think about a parity lens, or use a parity lens to think across multiple levels, not just network adequacy, but also payment, which we've talked about, quality, and then service utilization.
Great. So let's get back to the quantitative component of parity. Look, we all know that we've been talking about the problems, the disconnect between the need for mental health and access. So even before the pandemic, about 20% of adults were living with a mental health condition. And again, that's before the pandemic. Things got a whole lot worse during the pandemic. We also know that about 4% of all health plan spending is on mental health care. That's a bit of a disconnect. Even though there are equal visit limits and copays for mental health care have been addressed to a certain extent by health plans, behavioral health providers still argue that payment parity is lacking, that they don't get paid enough to join insurance networks. And this gets us back to network adequacy, but it also brings us to how much it takes for a mental health provider to provide care. And is there something to think about here in terms of what it takes to provide mental health in relation to what it takes to provide physical health care? I'll open that up to anybody who has a comment.
I'll just jump in and briefly say that there's a really good blog post that I can drop into the chat, or anyone can drop into the chat, from MHA earlier in February, which kind of goes into the RVU system and the way that payment is actually decided upon amongst stakeholders. And there's particular people that are intentionally I'm thinking about consumers here, but there are particular people that are intentionally left out of the process of deciding what is valuable, how much time and money should be assigned for certain activities and practices. And so we know that primary care is often not valued as highly as other specialties. And we know that behavioral health services are also valued very lowly. And so there really needs to be internal power structures moved around to allow for some of the specialists to be paid less and accept lower payments, or value their time differently. And I might get pushback here, but I'm here on behalf of consumers, of what's good for the patient, so that there's additional increase in payment for behavioral health specialists or primary care who are at the front lines kind of doing this work on behalf of some of the behavioral health specialists. So we need to move towards advocacy within some of the hidden behind the scenes stakeholders who make decisions about payment and what's valuable and how much time should be spent doing this versus that, so that behavioral health services are more higher valued.
Gretchen, how do Medicaid agencies look at this, and who decides what to pay and for how much time, and how does that work from Medicaid's perspective?
Sure. So thank you for that. Just as a reminder on the basics of Medicaid. So every dollar spent by a Medicaid program has a portion of it that is federal and a portion of it that is state. And that varies by the population that's being served. So children and pregnant women, for example, are at the state regular match. So 50-50 for the state of Colorado, whereas an expansion adult is 90-10. So 90 cents of the dollar is federal and 10 cents of the dollar is state. So I raise that just as a reminder that state funds are a part of Medicaid payment. And so state general assemblies or legislatures have a role to play in deciding what benefits are covered and at what price point. So there are, as you said, Karen, there are legislative processes, hopefully mostly transparent, unfortunately sometimes less than transparent, that do sort of create, at least in the Medicaid space, an open conversation about where we're spending public dollars. There are also, though, requirements that things are what are called actuarially sound. So there are reviews of rates by state Medicaid agencies, in particular to managed care plans, to make sure they would cover the cost of services. That can create some disincentives, to be honest with you, on the focus on preventive care and on primary care services. There's often more focus on controlling higher cost care, and that can leave, as you said, Karen, not as much focus on places where a lot of important care is happening. So it is a state-federal partnership. State legislatures are involved, which means lobbyists and lobbying is involved. And hopefully it means a little transparency in the way choices are made. In Colorado, for example, it was a piece of legislation that led us to implement an inpatient substance use disorder benefit. It had not been part of the benefit package in Colorado, other than actually for pregnant women. But now it is a standard benefit because of an act of the Colorado General Assembly.
Kay, do you have anything else to add regarding payment, and is payment sufficient? And I'm curious about the Shades of Blue project. Do you all contract with behavioral health plans, and why not, and what has it been like in terms of billing and payment sufficiency?
So unfortunately, Marilyn, we do not. We have to refer out. So we have a great network of counselors, folks like that we work with that provide services on a sliding scale for us. Certainly looking forward to the day where community-based organizations are able to build and get that type of funding. But our reality as it sits right now is that's not an option for us. Something that we're certainly working towards and wanting to have happen, but no. But also the barriers that exist within those who do take the Medicaid, Medicare, all those different things. There's not enough providers that meet the requirements or even want to, because it's not enough money. That's what we always hear. It's not enough money. So just from what we know and what we hear, it's not enough money. And so oftentimes we are left simply where we are right now, is contracting with those who provide the services and then paying them on a sliding scale. So yeah.
Let me ask you all if you think that recent action is going to help with this, and in particular the supply and the supply of those that might be in network. But Congress at the end of last year decided, this is specifically for Medicare, to cover payment for licensed mental health counselors and marriage and family therapists, which are new to coverage for Medicare, maybe not to other payers. But is this going to help at all?
Absolutely, it would. I believe most Medicaid programs cover those kinds of mental health providers and depend on them greatly. I think there are some challenges when you have either county-based or safety net identified providers that can create a bifurcation in your network. So only if you work at a community mental health center, for example, versus the kinds of folks, Kay, you're talking about, who practice independently and are out in community, not the community mental health centers aren't, but are sort of independent operators. There still can be discrepancies between how those two provider types are paid. And there's a lot of focus on figuring that out. But absolutely expanding the workforce to those kinds of mental health professionals has been critical in state Medicaid agencies.
Okay. Anybody else want to weigh in on these payment issues before we move on? Okay. So one thing that did come up during our planning is that there are shortages of programs as well, such as hospital outpatient programs. And there's also this idea that we shouldn't have separate mental health insurance companies at all. Currently, if you call your insurance company and you have a question about a claim, it's often a whole different thing where the mental health section is there. So what about that? What about this shortage of programs such as hospital outpatient programs? And I'll just add in here that, we just had the introduction last summer of the new 988 crisis response system, so that, of course, anybody who feels they're in crisis can call 988. What we do know about this is that there is concern not only with just funding those call centers and getting response teams to people who are in crisis, but it can be a real cyclical thing where if you don't have the infrastructure to work with people once they call 988 and go through that immediate process, what's going to happen to them then? They're going to cycle back through and keep calling and calling and calling, and that person never gets the longer term help that they need. So any thoughts about programs that are necessary?
I think this is where community-based organizations come into play. You're right. It's going to be a cycle funnel through. It's not the same thing that we experience in an organization. If one organization doesn't offer what you need, you go to another organization. But what we have to do now is be more minded around the collective effort. There's lots of programs out there. Honestly, I don't think the shortage of programs is the problem. I think us knowing about these programs and how to get them to the people who can best utilize them is really the bigger problem. And so this is where, if everything is put into a box, right? If only, doctors, nurses, these type of professionals are able to be the go-tos, then everybody outside the box doesn't get to assist. So this is what I mean by this has to be more of a collective effort, because then something like 988 would not be working, right? If someone is continuously calling, if that's their go-to, then there's a disconnect. They're not being connected and put in front of the folks that could actually help them. But that's collective effort, having a really truly vetted, we, in providing social support services, we have a list, right? That list has to be constantly updated, and I tell you, like 3 times a week. because you never know what someone is going to stop offering, what they started offering. It's on the continuum. So understanding that is, again, the biggest piece to that. But it's not a shortage of projects. When it becomes a shortage of programs and projects, that's because of funding. Because you can only do this work for so long with no funding. And so that is typically how organizations fall off. But then someone else comes in, right? And it's like recycling in and out. But that's the piece. This is how we have so many folks to kind of fall through the cracks.
So let's get down to business as our time for this panel comes to a close shortly. Let's get down to business. We've talked about problems. We've talked about what this looks like on the ground. Let's talk about solutions. And I'd like to hear from each of you about if you could change something, if you could, what is the one thing that's really keeping you up at night that you would like to see changed, and how would you like to see that change? What do you think would make the most difference if you had your magic wand and could wave it and do this? What would you do? And let's start with Gretchen.
Sure. So I am really intrigued by, and we've explored it quite extensively in our panel, but the role of sort of group support, both formal and informal group support, is really critical. I had the chance one time to sit with some Medicaid managed care companies, and I said, what would be the one thing you would solve? And they said loneliness and isolation. And I think in particular for women and birthing people in the immediate postpartum period, it's incredibly isolating. Not only a time of great hormonal change and risk, but it's just an isolating period of time. And so I think group prenatal care, group postpartum care, those kinds of programs that are still clinically oriented and still connecting people to resources, but much more about building community and finding ways, I think, as you have said, Kay, to get health insurance companies, including Medicaid programs, to pay and to value the importance of connection to community. That is where I think we have to continue to focus. It's really important that we have psychiatrists and other sort of more specialty behavioral health providers. But to me, I think our focus needs to be more in those community connection activities.
Are some Medicaid programs already doing this? I know that many of our states have Medicaid managed care organizations and have some pretty significant flexibility to be able to do things like this.
Yes, absolutely. And group prenatal care at federally qualified health centers, the Centering Pregnancy Program, there's quite a few of them, and they have shown, similar to what Dr. Bush showed yesterday, incredible connectivity and long-term positive relationships when women and infants have the chance to bond together and sort of move through those clinical processes together.
Great. Kay?
Well, Marilyn, my magic wand would bring us a lot tighter together, and not just use community as kind of like a paraphrase, and that we in some kind of way put the compassion back into healthcare overall, and that we just honestly see the individual that is sitting in front of us, and that folks are not treated like numbers, that they are treated like people. I think across the board, if that was a shift in how we do this work from a compassionate place, that too will come into place all the way across from advocacy to policy. We're certainly disconnected and disjointed from what community actually is. So that's what my magic wand for the opportunity to really shift this around would be, is for us to put compassion back into what it is and how we interact with folks on a daily.
Karen?
I agree with the prior points by Gretchen and Kay. And I'm thinking that, back to my point about the #1 demographic coming to MHA's website, 11 to 17-year-olds. And so it's thinking about how much earlier on during the 0 to 3 years, the perinatal period, and how we can support families when they have children, adolescents, how we can support them there. And that's community initiated care, that's valuing some different things and linking them to health services. So ensuring there's maybe a concierge or administrative person within clinical settings to help with connecting people to care in the community. And to really value that as just as important as ensuring an individual gets the screening or surgical response that they might need, because we know that if you treat the health condition without the other social determinants, you're only 30% likely to make change. You have to treat the other kind of social and community things that are going on, and help with elevating those supportive determinants of health to really make 100% impact, which I think most providers really want to do. I don't think people go into the medical system wanting to only help people this much. And I'll also just mention that there's a whole I think discrimination that happens against people who might not have BAs or advanced degrees, but however have great interpersonal skills that help with just connection and that's kind of belonging. And so it's allowing people like peer support specialists and community health workers and others who have less formal training maybe than someone who went to 7 years of school, but who also bring their lived experience into the room or into the community setting and value the recovery of an individual just as much as a well-paid provider. So there is the PEERS Act that we passed last year in the Consolidated Appropriations Act, which will allow peer support specialists to be covered in integrated settings and as part of mobile crisis teams for Medicare beneficiaries. And we hope that private insurers will kind of follow that lead and start to take initiative to educate themselves on what peer support is and how they can incorporate peer specialists into workflow in ways that honor peer support and honor the individual lived experience.
I think all of these, everything that the three of you just said really speaks to the need to make the best use of what the resources that we currently have in the mental health system, which entails being creative where we can, involving the community, involving peer supporters, integrating mental health with physical health so that we get people working together, we're going to have better results. So Amber, I'm not going to ask the question to you in exactly the same way because you are already part of the solution, but are there things that, are there priorities for you all at Labor that you think are really important right now? Is there something in particular you want to mention that you all are heading toward that you think is going to have a very important effect?
Yeah, I think this has been a great discussion just to hear where you all are coming from, the various perspectives. And it sounds like we're all kind of thinking about things, with the same challenges in the same way. And I think really it sounds like where we're focusing on is trying to push on network adequacy. I think we're looking at a lot of the challenge there. I think there are, as we acknowledge it, there are things that we can't do things about immediately because they are maybe outside of the scope of what's allowed, and we might need Congress to act. There might be provider shortages and longer term solutions. But that being said, I don't know that means we stop pushing on what we can do today. And so I think really it's about identifying what can be done now with the tools that we have and then working towards building upon that. And so I think from our perspective, we're trying to kind of challenge payers to see what they can do to make sure that individuals can access care, because I think there's a real crisis here. And I think that even looking past COVID and things of that nature, it's really close to home for a lot of folks. And I think really we need to work together to make sure that we can provide robust coverage. And, I think you had also mentioned earlier about, I think you were kind of leaning in on managed behavioral health organizations, and we're already layering in complicated things on a complicated area where health literacy is a issue that is, around the country. And I think this is a challenging area for people to understand their benefits and just trying to think about ways to connect what is available in a clear and concise way so that individuals can just know what's out there. And so I think really we're looking to help in the network adequacy space. I think we're trying to conduct a lot of outreach and engage individuals to know what protections are available. I think we are trying to partner within our department. There are other agencies that work in the space, but also across the administration. And so I think you'll continue to see a concerted effort to really use the tools that are available to us to really try to achieve meaningful access to individuals in a very challenging space when it usually comes at a very challenging time in a family's life.
Many thanks to all of our panelists for a super rich conversation. I'm going to turn this back over to Joy. Joy, it's all
Thank you
yours.
so much, Marilyn and panel. And I, of course, always have thoughts on these topics, and wanted to thank the Department of Labor for their leadership. And, I really believe it's time for health plans and insurers to get creative. There are shortages, but there are also creative ways to address those shortages. We heard from our speakers on Wednesday the importance of community-based support and interventions that are already covered under the U.S. Preventive Services Task Force for providers, and things like we heard today about providing support groups, right? Alex Briscoe said the future of mental health is support groups and community interventions. We believe that's true. So lots of great work. Insurers and plans can do more to make available support groups in their provider directories, for example. They can even offer consultation to obstetric providers and primary care providers to support them in doing mental health work on the front lines. So exciting conversation. Thank you again to the panel.